Good afternoon, everyone. Welcome to our presentation on forecasting healthcare statistics. My name is Mike Lewis with the Cleveland Clinic. I'm a Senior Director in our Enterprise Analytics Department, and with me is Michael Bromley.
Yeah, my name is Mike Bromley. I'm a Senior Analyst and Data Scientist at Cleveland Clinic, and I've worked with Mike for the last 6 years here.
So let's talk a little bit about the business story here. So one of the things that we were working on doing is trying to improve our analytic maturity. So many of you have seen this driving analytics maturity curve where we're starting at reactive decision making. We're all really good at this stuff, right? We've all done our ad hoc reporting and standard reports for years. And now we're really trying to drive towards that more proactive decision making. So in order to do that, we produce a lot of corporate statistics. And when thinking about the corporate statistics, we've used very basic models. So in order to try to drive maturity, we tried to implement some discipline forecasting techniques. And we had a lot of different things we needed to address with this project. First were some institute challenges, and those were really just around the end users themselves. How could we get everyone to understand the information and interpret it the right way? And then also, how do we train the users in their ability to interpret and use these results? Again, for the organization, this is the first time that we were kind of introducing all these new methods, and we were trying to move forward with a way to help the organization understand how we can use these new methods going forward. So when you think about where did we start, you're thinking about we had a very basic model. So this yellow line was kind of our projection, and you can see a very flat line at top. At the bottom was a flat line there, and those kind of represented the week and weekends. And you can see the actuals in the blue, kind of how the model would perform against that. So we'd have peaks and valleys, and we were always running into issues of why did we miss the projection or why did we come in under the projection. So when you think about where we needed to move, it was really getting back to things around what was our ultimate goal. We had situations where we couldn't account for variables in conferences and things like that. So what we did was we introduced a financial statistics dashboard, and the goal was really to figure out how could we replace our current projections with some time series models. And we wanted to develop something simple and streamlined so that the end users could forecast, take the forecasted results, consume them, and then improve their operational statistics. So again, I'm going to turn it over to Mike Bromley. He's going to talk a little bit about the featured engineering and model development of this process. Mike?
All right. Thanks, Mike. So I'm going to kind of talk through the whole sort of life cycle of the model build. But I'm going to start with a pretty generic slide on the model building process, right? So it's going to seem very linear when I step through these slides, like we did step 1 through 10, and then we were done. But it's not. I'm sure most of the people watching this know it's really not like that in reality. We went around this circle 100 times maybe. I mean, we kind of restarted and rethought of ideas and realized they were terrible and then started over and revalidated. So just kind of keep this in mind as I step through because it's not as linear of a process as it may seem in here. So we know that we're working on a forecast, right? But what are we actually forecasting? We talked about corporate statistics. It's what we call kind of key metrics here at the Cleveland Clinic. But really, it's those 6 kind of metrics listed on the top left, right? Key healthcare volumes that essentially drive the business. So what we're going to need is daily output for at least 12 weeks. If we could predict 10 years, they would love it. But let's kind of keep it realistic, right? So we're going 12 weeks for those different metrics. And when you start to think about what do we actually need to understand to make a decision, maybe there's a decision that we could make with high-level surgery, right? Okay, from an organizational enterprise standpoint, maybe we can use that for something. But what we really need to know is, where are they happening, what facilities, what institutes, what departments, what substats. So that's kind of what this decision tree-looking thing at the right is. It's an example of these are the things we need to understand and get out of a forecast. But if we start to split levels that detailed, we get to that 7,500 number, which is, okay, we have 7,500 forecasts. Well, that's a lot. I mean, it is certainly possible to take some of the commercial tools out there and throw data at it and have it spit out a bunch of forecasts, but you start to lose a little bit of that signal at the bottom levels. Demand, your volume is sort of intermittent, and it's a lot harder to build and pay personal attention to that many model levels. So what we're going to do is kind of a combination. We're going to use SAS Forecast Studio, which is it's one of those tools I mentioned. We can take a bunch of data, throw it at it, and have it spit out models. But we're also going to apply Monte Carlo simulation techniques to kind of get us where we need to go. I'll talk a little bit more about the simulation in a later slide here. So we talked about model structure. We know we don't want to build 7,500 models. So this is kind of where we ended up, right? A little bit of a different structure depending on the statistic or the metric. So some of them were by institute, some by a combination of institute and facility and substatistic and so on. So this kind of gets us to, I think it was 498 models, so about 500 models. And any level that isn't going to be output from this model structure will be generated in the simulation, right? In the sampling that I'll talk about in a little bit. So we kind of understand. Okay, this is what our model structure is going to be, but what about the data? We don't have data, and I don't know many people that have data up to this minute. In our data, we have a lag. So we talked to our data stewards and came up with this table on the left. Here, if I go back one tick. All right, this table on the left, and started there. So we pulled data in, and we built some forecast models. And it kind of worked for some stats. It didn't work so well for others. And so we started to investigate, okay, going forward now, what's the true lag? Like where does our data truly start to be reflective of actuals? How far back do we have to go? And so those numbers on the right side is kind of where we ended up, increasing lag for admissions, discharges, and some of the different stats to account for coding. So we may know volume 3 days ago, but we don't know which institutes and kind of things like that. So coding took a little bit longer to complete. And things like ED and observation. Observation was okay, but outpatient E&M needed a little bit more adjustment that I'll kind of talk about now. So even with a longer lag, right, there's kind of an example of it already showing up now. We don't really have complete data. So what we started to do, we wrote a program to track, okay, data that's 13 days old, how does it change as it gets older and older? As we move further in time and we say, okay, it's 13 days old, now how does it look when it's 20 days old? How does it look when it's 100 days old? We start to see this sort of shift up as data is actually completed until we finally get, oops, I went one too far. So we see this shift up, and this is kind of what we started to notice. And we don't want to put data that represented by the blue line into a forecast model because we're really going to project low. It's going to look like we're trending down. So we need to somehow get this yellow line to be reflected in our actuals. So there's two kind of ways we could potentially deal with that, right? We could increase the lag period. So we would need to realistically change it to almost 40 days. So essentially our first projection for true forward projecting of data would be the 41st day in the model. I don't know how many people use the weather forecast for 41 days from now, but I don't think too many people actually believe what they see. So you can probably guess we didn't really go with that method. It was an option, but we didn't go with it. And the second option was, can we track enough of this phenomenon to actually adjust the data up before we feed it into the model? So that's definitely what we ended up doing. And what you ended up seeing was this kind of shift of, as we applied this change to The blue line on the bottom right, we pushed it up to, it was almost always up. There was a few cases where we adjusted it down, but we ended up adjusting data so that when we feed it into the model, we get a more accurate projection. So that's what it would end up looking like when we shifted it. Okay, so we've kind of talked through some of the components that we needed to finally get this model in. And at this point, like I said, we went around that circle a lot. We talked about model structure and data lag. We need to figure out what's the time frame. We talked about structure. We need to now talk about independent variables and some of their adjustments, where we've kind of adjusted our dependent variable, but we still have to think, okay, what kind of independent variables can we use to improve from that sort of flatline model? Can we put things in there like holidays? Can we put schedules and things like that in there? So this is actually the final list of some of the important variables. The list is a lot longer than this, but these are really the ones that are most impactful. So some of your standard variables in there, like a flag for weekends, flags for holidays. We had some holiday weighting depending on the effect that a holiday had on volume before and after and things like that. But the major ones here are those last three. I call these the schedule variables, right? So we have actual surgeries scheduled. We have what's called patient slots, which is representative of a time slot on a physician calendar where they are available to see a patient. So this really drives outpatient E&M volume. And then PTO. So I don't know if that's really a schedule, but it's when physicians go in and say, okay, I plan on being out at a conference or whatever in 2 weeks. That definitely has an effect on surgeries and admission volume. So we're going to talk a little bit about those three variables now. So how can we actually leverage these? When you throw the surgery schedule into a surgical model, for example, it's great. Like your model stats are awesome. Your R-squared is at 0.99. Your MAE is way down, and you think, great, my model is going to be amazing. But then you kind of see this orange line because the future schedule is not populated. And so your model stats may be amazing, but you actually get this, unless you really think your volume is going to do that, which could be a problem, you're probably thinking, yeah, this isn't right. So we need to do something here. If we're actually going to use this, we have to think about adjusting kind of like our dependent variable earlier. So again, a couple different solutions. We could take the schedule and forecast it, and then use it as a learned feature in our original model. Or we can do something similar to what we did with our dependent variable, which is track the shift. So track how does the schedule change the closer we get to it being tomorrow. So we actually kind of do both of these things. We have a combination of using actual available patient slots along with a projection, and then for the physician PTO and surgical schedule, we do a little bit of an adjustment, just like our dependent variable. Okay, so now we've kind of applied a similar adjustment. We've adjusted our dependent. We've adjusted our independent variables. We kind of went around that circle a whole bunch of times, and now we're finally at this point where we're like, okay, what are the actual models we're going to use to get our projection, right? And it's kind of we use SAS Forecast Studio, and we throw a bunch into the blender, or I guess this is a funnel, and out comes a champion model, right? So for us, it's going to be models that have very correlated independent variables, so schedule for surgery, physician PTO for admissions, and slots for like established or new or consultation E&M visits. Those are pretty much all going to be ARIMA or ARIMA-X models. Models that really don't have a great independent variable to inform them, but have a lot of volume. For example, emergency department. There's a lot of randomness associated with that. Those are going to fit best to ESM, exponential smoothing model. And then that last one in the funnel there, those intermittent demand models will be pretty exclusively used for those lower levels or those model levels where there's very little volume and kind of sporadic demand coming in week to week. And all of these are kind of thrown at Forecast Studio, and based on the holdout MAE, which is 150 days, a champion model is selected. So not a lot to talk about on this slide, just thought it was pretty important to put out some of the high-level model stats. Like I said, models that have a schedule variable in them have really nice model stats, but you can't always trust them, since no matter what, the model stats are going to be amazing and the forecast might be completely awful. Luckily, when we apply the adjustments, the surgery is an outpatient E&M and things like that, still has a pretty nice projection to go with it. So real quick, kind of talk about the simulation portion. So I know I mentioned this a few times earlier, and this is kind of our technique for getting to those model levels that we don't have getting to the output levels that we don't have a model level for. And so, for example, if we have a surgical forecast by facility, so by hospital, but we really need to understand, where's the volume by institute and department. What we can do is get the facility output from the model, and we can then use that forecast as the mean of a normal distribution, and then generate some random sample sizes and sample from our actual historical data to generate all the levels of detail that exist in reality. So what departments is the volume going to be in, what institutes, different things like that. So the big advantage for this is we can build less models, which is it's more manageable to manage 498 models than 7,500. But we can also change we get the levels of detail we need in the output, but we can also change either or, right? So we can leave the models exactly as they are if we think they're fit perfectly, but we can change around the output we get from the simulation, or vice versa. We can leave the output the same, but change our model levels without screwing up the whole process. So that's kind of the flexibility that we get from using this technique. And kind of just a fun fact, every time we refresh, we do about 4 million samples with this technique. We go next. Okay, so I think that kind of covers the model build. And now I'm going to turn it back over to Mike Lewis, who's going to kind of close it out with some of the output and user engagement slides. Mike?
Thanks, Mike. So, again, the big key here is really how do we make this easier to consume, and we try to follow 3 principles. We don't really ever want to try to show the complexity or show the math. It's really about how do we make it easier to consume and integrate it into our workflow. So when you think about that, we integrate this information into their workflow, and then it's really about keeping end user engagement. So we have weekly discussions with our teams on this, where we talk about the model build, and then we talk about accuracy. We ask them for things that are going on in their workflow to help us understand, are there other variables we can do? So this user feedback and user engagement is a critical step as we move forward. And when you really think about it, we're ultimately asking them to change the discussion, right? It's how do we change the discussion? And when you think about the forecast, it's ultimately around, can we make a decision? So it's not, is the forecast right or wrong? It's looking at the forecast, it's looking at the projections and say, is this accurate enough to make you change your decision knowing this kind of information? So again, we also continue to do long-term model tracking that we help the end users understand. So we track all this stuff over time so we can understand model degradation. And finally, when it is ready for production, it is ultimately that final slide that you're seeing here, which is, we've done all these steps, we've deployed it, and we are engaged with our end user. So again, Mike and I want to thank you for joining our presentation on forecasting statistics. and we hope you enjoyed our presentation. Thank you.